I'm short. So before I start my presentation, thank you to the organizers and the scientific committee for giving me this opportunity. And another thing I would like to talk, Dr. Neo sir, yours was an excellent presentation. And please remember, language and fluency is never important. If you're able to put forth what you want to say, that is all. That is really all. So the fluency in language, knowing the difficult words, it never matters for a teacher. And I really wish there are more and more teachers like you. Thank you so much. So I learned a lot of ENT today. It was so difficult always to understand. You made it so clear. Thank you so much. So coming to my topic, quality of life. So like sir was saying, this is something not given much of importance. So what do you people perceive as quality of life? Anybody would like to give some ideas, some inputs? Keeping comfortable. Keeping the patient comfortable. Okay, yeah, that is very important. What do you say? You feel, if you feel, make the patient feel comfortable, that is good quality of life. Okay, ma'am. To some extent, yes, we can say, but this is not just keeping the patient comfortable. It is more, it goes into more depth. So it is like multi-dimensional concept, right? And here it will incorporate not just the metrics of the patient, the values, what they see. Like it is not just the physical well-being, it is emotional and social well-being also, which is taken into consideration. And like sir was saying, it is one of the 5 important parameters of treating the patient. So it is, again, it becomes a very important health outcome. So again, it will represent the ultimate goal of what you are doing to the patient, what all interventions you are subjecting to the patient to. It is the ultimate goal. So that is what the quality of life is in short. So I was also wondering what is quality of life, and then I searched and I found that WHO has defined it as individual's perception. So it is not your or my perception towards how the patient is, right? So it is the patient who's going to judge their quality of life. So it is not, we are not going to judge, it is the individual's perception of their position in life in context to their culture, their value systems in which they live, and in relation to their goals, expectations, standards, and concerns. So 2 people living in the same household, getting everything same, having the same disease, they may not, their quality of life may not be same if you take it as an individual for them. If you give them the questionnaire, if you ask, each one may have a different goal, different understanding, right? So it differs from person to person. And it will take into account all these things, the physical health, the psychological state, the level of independence, personal beliefs, relationship with environment, social relationships, and many more. So these are few to talk of. And we all know when we talk of diabetes, it is the complications and the comorbidities associated with diabetes which take a toll on the patient's health. And the problem is nowadays we are teaching the patient so much about diabetes and how the value should be, how much your fasting should be. We are giving them goals. We are telling your HbA1c should be less than 7. You are young, it should be less than 6.5. Your lipid should be less than 70. Even lesser, it is better, 40. So you're bringing down the things. So now when the patients come to you, they come with the reports and they see what is normal on the side. And they are bothered. Even one small thing which may not be very relevant, they are bothered by that. So that simple thing will spoil, it will reduce the quality of life. So this is all I'm going to talk about now. So the more the problems are there, the more the diseases, the more the comorbidities and complications, it is going to affect the quality of life. Now in diabetics, it decreases in patients and it becomes even worse when they develop the complications or comorbidities, and it will negatively affect the physical well-being. And the 4 major ways in which it affects is because of the increasing duration of disease, the complications, the long-term complications occur. Then of course the short-term complication, and among the short-term complication, most important is the iatrogenic, the hypoglycemia the patient faces. So that is very, very important. We are the reason for the reduction in the quality of life in that patient when we are over-treating the patient with drugs. Then the side effects of the drug, again, those are the short-term complication. Any adverse effect, your SGLT2 inhibitor gives a urinary tract infection, a pyelonephritis, it is a problem, right? So patient may get admitted. any alpha glucosidase inhibitor causing dyspepsia, bloating, flatulence. So they find it very difficult to move around in the society. So all these things, they add on to the quality of life. And that it demands, the demands which are imposed by the treatment regimens. So multiple injections to be taken. These are the demands. They have to take the drug before food, after food. Remember to take it 30 minutes before food. Remember to chew it with the food. So these are the demands of the drugs we are giving. So again, all these things, they impact the quality of life. And then everything together, it will affect the psychological functioning via its impact on the mood of the patient. Now we have multiple tools available. The few important ones for the general quality of life, the WHO quality of life questionnaire is there, and the diabetic specific tools which are commonly used or which are more popular are the diabetes quality of life and audit of diabetes dependent quality of life. You can go up, you can go through all these online. It is easy, and I'm not going to talk because there are long questionnaires. WHO quality of life BREF has 26 questions. SF36 has 36 questions, quality of life in diabetes has 34 questions. So it has domains, various domains, physical, mental, and each one will have questions and the patient has to answer them because it is the personal perspective of the patient. So what are the determinants which affect the quality of life in a patient with diabetes? It is the type of diabetes, the duration of diabetes, the glycemic control, right? So poorer control, they will have more symptoms related to poor glycemic control, hyperglycemia. Then the gender, commonly it is seen females have poorer quality of life when compared to male in various studies. Then the complications developing because of diabetes or the medications. Then the various treatment regimen we are subjecting the patient to, be it for insulin or other drugs. Then the psychosocial factors. So all these factors, they determine the quality of life in patient with diabetes. So coming to the type of diabetes and duration, so usually it was seen in type 1 diabetes, the quality of life was better, right? When we think that it is injections only which has to be taken, but maybe because these patients are younger, more energetic, and one shot they don't really mind. So there it was seen that the quality of life was better in type 1 diabetics than type 2 diabetics. And in type 2 diabetes patients who had a longer duration of diabetes, the quality of life was poorer. Coming to gender, as I already said, poorer in women. And the sleep quality was also poorer among the female population in type 2 patients. And when we talk of glycemic control, again, poorer control was associated with impaired quality of life in both type 1 and type 2 diabetes. What about the complications? As expected, neuropathy and nephropathy, they have been shown to be associated with lower quality of life compared to other diabetes complications like retinopathy. So retinopathy, of course, it is usually not symptomatic unless it goes to severe, very severe and proliferative retinopathy. And again, poorer quality of life if the retinopathy is proliferative compared to non-proliferative. Now quality of life and treatment regimen. It was observed that patients who were given a single or 2 drugs regimen, their quality of life was better compared to when there was a combination regimen of oral drugs along with insulin. And again, treatment satisfaction of patients who were receiving metformin alone or in combination with glipizide or a single drug, that was better than in patients who were receiving multiple oral hypoglycemic agents with or without insulin. Psychosocial factors, depression, it was one thing which was significantly more prevalent among people with type 2 diabetes, and it was associated with poor quality of life. And then in another study it was shown that type 2 patients with and without depression, they reported that in presence of depression, quality of life deteriorated. What about the comorbidities, metabolic syndrome, obesity? So stroke, it had a high negative impact on physical health related quality of life. Presence of comorbidities, it affected the physical component summary and mental component summary of short form health survey. So these are some of the questionnaires which are used for assessing the quality of life. So here it was shown that comorbidities, they will affect in some way or the other, and those people who had visual impairment and stroke, they had significantly reduced quality of life. And among type 2 patients, with metabolic syndrome, a greater significant decline was observed in, again, the same two, PCS and MCS, as compared to those without metabolic syndrome. So those with obesity in general and multiple problems had poorer quality of life. Now this slide, it is very important. It is dedicated to my MD teacher, Professor C. Rajendran. So he was there yesterday for an oration, and I was at the end of preparing my slides, and I was wondering I was just thinking how to finish it off, and I didn't know what to do. And teachers, they always come and help you. So this is what all he has taught me. This is what all I learned. So how to improve? So finally, quality of life, we have to improve, no? You have to give a better quality of life to the patient. So how do we improve? So I'm not talking of lifestyle modification, we all know. But important part in lifestyle modification is when we advise the patient to stop taking sugar, don't use sweeteners, don't eat this, don't eat that. So they need to eat. They love something to eat. So you should also tell them what to eat, right? And you have to give them healthy options, and you should make it interesting. You can't just go on saying, they will ask, patient may be loving to eat some kanji. Then we'll say, no kanji. So, but let him have, just tell him to monitor the blood sugar, that's all. So let them have whatever they feel like, but again in moderation. Don't tell them don't eat mangoes at all. They can have a small slice. They should control. So that is quality of life. So again, important is lifestyle modification. When we talk of females, their quality of life is poorer. If you ask a female to go for walking, what do they say? I am having joint pain, I'm obese, I'm having breathlessness. So please advise them to do some kind of upper body exercise. Lie down on the bed and move your limbs. So you will decrease the weight. That will help in reducing the weight and keeping them more mobile and better. And they will feel better. So that is how lifestyle modification has to be advised to improve quality of life. Preventive aspects. Can we do something to prevent some So what preventive? To prevent development of complications of diabetes. So you have to advise them to be moderate with the salt, reduce the pickle intake, reduce the taking of caracolum. So all these things can be advised so that certain complications may not develop. Prophylactic, can we do something to some prophylaxis, like an elderly patient who's developing recurrent respiratory infections, can we not vaccinate that patient? It will reduce the respiratory infections in future. The pneumonia, the pneumococcal pneumonia vaccine can be given to give them a better life. Supportive, the most important, the tender loving care which a patient requires, the supportive treatment. So here we'll have to include the family also. So the family members, the friends, they can be included to give a good supportive care to the family. So that is very important part of not alone diabetes, any disease in the world. Then symptomatic. The pain is there, you have to give a pain relief medication or whatever symptom, burning feet or headache, whatever they are having. So symptomatic treatment is again very important part to improve the quality of life. Then curative. Is there anything we can cure? No, hardly anything in diabetes. But still, there will be some small problems which you can give a cure for. Palliative. If neuropathy pain cannot subside, what palliative care you can give? Maybe we can subject them to pulse electromagnetic field therapy, something which can relieve the pain, they will feel better. Or at least some painkillers, tramadol, any opioid analgesics. Then the treatment of complications, including the treatment of iatrogenic complications. Withdraw the drugs which are causing the problem. Don't restart it again. Just because you want to give that drug, it is told that it has better effect on the heart failure hospitalization. Come on, the patient never had a heart failure. Then you can leave that drug. If he has, after that you can add it on. Give him some peace of mind. Physiotherapy, psychotherapy, these are very important ones, but we hardly ever use these therapies for the betterment of patients. So we should include these also. Rehabilitation, a patient who has undergone an amputation, we can always advise them or help them with rehabilitation. If they have poor vision, how will they do their day-to-day activity? So for all those things, they require rehabilitation. So rehabilitation is another important part where the quality of life improves. And then, of course, most important, finally, the follow-up of the patient to see what you are doing. Is it improving or is it reducing what you wanted to do? So with that, I would like to end. Thank you so much.